Okay, let's unpack this. Have you ever watched one of those really intense medical dramas on TV?
Oh, absolutely. Like all the time.
Right. So you know the exact scene I'm talking about. A patient crashes, the heart monitors start blaring that terrifying high-pitched tone, and a doctor yells, "Get them on oxygen!"
Yeah, and then someone immediately sprints over to the wall.
Exactly. A nurse reaches over, grabs that little plastic dial, and just, cranks it all the way up. We have literally all seen it 100 times. It looks like they're just turning up the volume on a speaker.
It does. And I mean, it feels incredibly intuitive when you watch it on a screen. If
Right.
someone is struggling to breathe, the immediate logic is just, give them more air as fast as humanly possible.
Which makes sense on the surface. But today, we've gathered this massive stack of medical history, physiological research, and clinical trials custom-tailored just for you. Because our mission in this deep dive is to completely dismantle everything you think you know about oxygen.
Because it's really not just air, but better.
No, it's not. That dial on the hospital wall, it is not a volume knob. It's actually a medication dosage. And today we're exploring the fascinating engineering, the physiological stakes, and the hidden science behind oxygen delivery devices. From the humble nasal cannula all the way up to those heavy-duty trauma masks.
Yeah, and the core premise of modern respiratory care, like the absolute foundation of it, is that oxygen is formally classified by regulatory bodies as a prescription drug.
Wait, drug? Like literally classified as a drug?
Literally, just like any antibiotic or painkiller you might pick up at a pharmacy. Oxygen has a highly specific dose. It has a designated route of administration and very strictly defined clinical indications for when you should actually use it.
That's wild.
Right. And it also has highly documented, terrifying risks of an actual overdose.
An oxygen overdose. I mean, that phrase alone feels like a contradiction, We're taught from kindergarten that oxygen is life.
Yeah, it's the good stuff.
Right. But to really understand how we deliver oxygen safely today, we have to look at the tragic history of what happened when early doctors treated it like this limitless magical vapor instead of a precise drug.
Exactly. And to see where that limitless mindset really started, we have to go back to the brutal realities of World War I.
Okay, so the trenches.
Yeah, you had soldiers suffering from these horrific chlorine gas attacks. And the chemical would severely damage the alveolar capillary membrane in the lungs.
Which causes what, exactly?
Basically, acute pulmonary edema. Essentially, the lungs would just fill with fluid. The soldier is drowning from the inside, which leads to massive, fatal drops in blood oxygen.
God, that's horrific.
It's a nightmare. But a Scottish physiologist named John Scott Haldane stepped into this. Around 1917, he developed some of the first practical systems for delivering oxygen continuously to these soldiers.
Oh, so instead of just waving a tube in their face and hoping for the best.
Right, exactly. A sporadic whiff of gas wasn't going to cut it.
Which makes total sense in a battlefield triage situation. I mean, if a soldier is effectively suffocating on their own lung fluid, continuous oxygen sounds like a miraculous lifesaver.
Oh, it absolutely saved lives. Haldane's work laid the critical foundation. But the true nuances of oxygen therapy didn't really start to surface until an American physician named Alvin Barak came along.
Okay, when was this?
This was working from the 1920s through the 1940s. Barak invented the oxygen tent.
Like an actual tent over the bed?
Yeah, imagine a large, clear plastic canopy suspended over a patient's hospital bed, tucked under the mattress to seal it, and he would just pump oxygen into this closed environment.
Seems pretty straightforward.
It was, but Barak noticed a big issue. These tents were hot, they were claustrophobic, and incredibly difficult to regulate.
Oh, I bet. If you open it, all the gas escapes.
Exactly. Every time a nurse unzipped the tent to check the patient, the oxygen concentration plummeted. But more importantly, Barak began to suspect that bathing someone in pure, unregulated oxygen for days on end might actually carry some hidden dangers.
See, if Barak was noticing these red flags way back in the 1930s, I have to wonder why the broader medical community didn't immediately start treating oxygen with strict precision.
Well, it's about what you can see versus what you can't.
Right, because, and let me use an analogy here. If I have a dying houseplant, right, and I know it needs water, I might assume, well, a little water saves it, so an industrial fire hose must be even better.
That's a great way to look at it.
But a fire hose is just going to blast the dirt away, rip off the leaves, and completely drown the plant. So why did it take so long for medicine to see the fire hose effect with oxygen?
Because the fire hose effect with oxygen isn't always immediately visible on the outside of the body. The damage happens at a microscopic cellular level.
Oh, wow. Okay.
Yeah. So the medical community didn't truly grasp the severity until a massive cautionary tale unfolded in the 1940s and 1950s.
What happened?
At that time, incubator technology for premature babies was rapidly advancing, and doctors desperately wanted to give these tiny, fragile infants whose lungs were severely underdeveloped the absolute best possible chance at survival.
Which, of course, you want to do everything you can.
Naturally. So they placed them in these new incubators and just flooded the sealed environments with unmonitored high-concentration oxygen.
They turned on the fire hose, thinking they were giving the babies a pure, healing environment.
And it caused a catastrophic epidemic. It's a condition called retrolental fibroplasia, which modern medicine now knows as retinopathy of prematurity.
Retinopathy, so it affected their eyes.
Yes. When you flood a premature infant's bloodstream with excess arterial oxygen, it actually halts the normal growth of blood vessels in the retina.
Oh, no.
And then when the baby's eventually taken out of the incubator and returns to normal room air, that sudden drop in oxygen triggers an explosive abnormal growth of leaky, fragile blood vessels.
And that damages the eye.
Severely. These vessels scar and physically detach the retina. This well-intentioned practice ended up permanently blinding thousands of infants across the U.S. and the U.K. Thousands. Before researchers finally linked that unmonitored high-concentration oxygen to the blindness.
That is absolutely devastating. I mean, they were focusing so intensely on saving the infant's lungs, and that literal overdose of a quote-unquote healing gas permanently took away their sight.
It's horrific. And it remains one of medicine's most cited heartbreaking examples of the principle that more is not necessarily better. It definitively proved, at a massive cost, that oxygen has a strict therapeutic window. Too little is lethal, but too much is highly toxic.
Right. So if giving patients, especially fragile ones, unregulated oxygen caused epidemics of blindness, the immediate panic for doctors must have been, well, how do we measure and control an invisible gas?
Exactly. They needed precision.
And that necessity for control birthed what is essentially the most important split in modern oxygen devices, right? The split between low-flow versus high-flow systems.
It's the one.
So how did they actually solve that engineering nightmare?
Well, they actually had to abandon traditional medical thinking entirely. To understand this leap, we have to look at 1960s Edinburgh. A physician named Dr. J.M. Campbell was watching a terrifying clinical pattern unfold in his wards.
What kind of pattern?
Patients with COPD, chronic obstructive pulmonary disease, were coming into the hospital with severe breathing flare-ups. Doctors would give them empirical oxygen from standard leaky phase masks.
Just standard procedure, right?
Right. But instead of getting better, some of these COPD patients would slip into carbon dioxide narcosis. They'd get confused, excessively sleepy, their breathing would slow down, and they would literally slip into respiratory arrest.
Wait, so the standard masks were essentially suffocating them with the very thing meant to save them.
Exactly, which is why Campbell looked outside of medicine and went back to an 18th century physics principle called the Venturi effect.
Okay, I want to make sure we really grasp this, because this is cool. Think of putting your thumb tightly over the end of a running garden hose. You narrow the opening, and the water suddenly shoots out much faster.
That is a perfect visualization.
Yeah.
If you force a gas or fluid through a narrowed section like a bottleneck, the velocity drastically increases, and the pressure actually drops.
And that drop does what?
That localized pressure drop creates a vacuum effect. It can literally suck in surrounding air. So Campbell used this 200-year-old physics concept to build a revolutionary medical mask.
Okay, how did the mask work?
He engineered a device where pure oxygen shoots through a tiny narrowed jet into the mask. And because it's moving so fast, it acts like a vacuum, pulling in a very specific, mathematically predictable proportion of room air through little open windows on the side of the plastic valve.
So the mask itself is actively mixing the pure wall oxygen with ambient room air before the patient even takes a breath.
Exactly. And because of the strict physics of the Venturi jet, the ratio of pure oxygen to drawn-in room air is perfectly constant. Yeah, Campbell's invention, the Venturi mask, can guarantee an exact percentage of oxygen, typically anywhere from 24% to 60%, depending on the specific color-coded valve you snap onto it.
And it doesn't matter how the patient is breathing.
Not at all. It delivers this exact concentration, regardless of how fast, how slow, how shallow, or how deep the patient is breathing. It was a monumental shift to what respiratory therapists call fixed performance devices.
Which means we need to break down a massive misconception that I found lurking in a lot of the nursing school cheat sheets and textbooks we reviewed for this deep dive.
Oh, the flow rate issue.
Yes, we need to clearly separate flow rate from FiO2 because these two terms get used interchangeably on medical shows all the time, but they measure completely different things.
Right. Flow rate is incredibly simple. It's just the speed at which the gas is physically coming out of the wall of the tank. We measure it in liters per minute.
So if you turn the dial to 2, exactly 2 liters of pure oxygen flow through the plastic tubing every minute.
Exactly. But FiO2 stands for fraction of inspired oxygen. That is the actual final concentration of oxygen that successfully makes it down into the patient's lungs.
Okay, here's where it gets really interesting. Because a lot of charts will confidently tell you that 2 liters on a nasal cannula equals exactly 28% oxygen. But in reality, that is a total myth, isn't it?
It is a massive oversimplification. It completely ignores human behavior. Low-flow devices, like that standard two-prong nasal cannula you see on every single hospital TV show, those are variable performance devices.
Variable meaning it changes based on the person.
Yes. Because a flow rate of 2 liters per minute is far below the actual speed at which a human being inhales. When you take a breath, you inhale at peak flows of maybe 20 to 30 liters per minute.
Whoa, okay, that's way faster.
Right. So when the patient inhales, they aren't just breathing the 2 liters of pure oxygen trickling from the tube. They're forcefully sucking in massive amounts of surrounding room air to make up the difference.
I love this. Think about the last time you ordered an iced Americano at a coffee shop. Right?
Okay, I'm with you.
The flow rate of oxygen coming out of the wall, that is your shot of espresso. It is a fixed, steady amount of the strong stuff. But the final strength of your drink, the FiO2, depends entirely on how much milk you pour into the cup with it. And in this scenario, the milk is the ambient room air.
That's brilliant. And what's fascinating here is how wildly that milk volume changes from minute to minute.
Right. Because if a patient is relaxed, they're sleeping and breathing slowly through their nose, they get the espresso with just a little splash of milk. It's a strong, high-concentration drink.
Because they aren't pulling in much room air.
Exactly. But if a patient is in severe respiratory distress, panting fast and shallow, or breathing heavily through an open mouth, they are gulping down huge amounts of room air. They are flooding their espresso with milk.
Yeah, the drink gets incredibly weak.
Meaning the actual oxygen concentration hitting their lungs plummets, even though the dial on the wall hasn't moved an inch.
Exactly. 2 completely different patients placed on the exact same 2-liter nasal cannula can receive drastically different oxygen concentrations in their bloodstream. They dilute the oxygen themselves with every single breath.
That is wild.
And that's why Dr. Campbell's Venturi mask was such a medical breakthrough. It provided high enough total flow to exceed the patient's inhalation speed, taking the unpredictable variability of the patient's breathing pattern completely out of the clinical equation.
Okay, so if a standard nasal cannula is so unpredictable and a patient comes into the emergency room needing a huge amount of oxygen, why can't we just crank the dial up to 15 liters on that standard nasal cannula? Like, just force way more espresso through the tube to overpower the milk.
Because you slam into the hard physical limits of human anatomy. A standard nasal cannula practically tops out at about 6 liters per minute.
Which gives you what, like 40%?
Under perfect breathing conditions, roughly a 44% IO2. If you turn the dial up past 6 liters on those tiny prongs, you don't meaningfully increase the oxygen concentration in their lungs. You just recreate a Category 5 hurricane inside their nasal cavity.
Oh, that sounds agonizing.
It really is. The sheer velocity of the dry, cold gas strips all the moisture from the mucous membranes. It causes severe burning discomfort, mucosal damage, and almost inevitably leads to massive bloody noses. The human nose physically cannot handle that localized flow.
Okay, so when the basic cannula maxes out and hits that anatomical ceiling, we need an engineering hack.
Exactly.
And that is where the non-rebreather mask enters the picture. This is the intimidating, heavy-duty mask you see strapped to trauma patients on TV. It covers the entire nose and mouth, and it has that distinct kind of deflated-looking plastic bag hanging off the bottom of it.
Right, the reservoir bag. And that bag is a stroke of pure engineering genius. The core physiological principle to remember here is that reservoirs increase deliverable FiO2 without requiring you to push the flow rate to anatomically impossible levels.
So how does that actually play out when you strap it to a patient?
Well, when a respiratory therapist connects a non-rebreather to the wall oxygen at, say, 15 liters per minute, that pure gas doesn't just blast into the patient's face. It routes down and fills up the reservoir bag first.
Oh, so it's a storage tank.
Yes. While the patient is exhaling, or simply pausing for a fraction of a second between breaths, that bag is actively inflating, stockpiling pure oxygen. Then, when the patient takes their next deep, desperate breath in, they draw directly from that bag of stored 100% pure oxygen.
Rather than pulling an empty room air from the hospital room.
Exactly.
But wait, if they're breathing in and out of a closed mask, what keeps them from just exhaling their own carbon dioxide right back into the bag and then rebreathing it?
That is where the non-rebreathing name comes from. The mask utilizes a series of simple but brilliant one-way flutter valves. They look like little rubber discs.
Oh, I've seen those on the sides of the masks.
Yeah. So there is a valve situated between the mask and the reservoir bag that only pops open when the patient inhales. And there are valves on the outside of the mask itself that pop open outward when the patient exhales, venting the carbon dioxide into the room.
That's so clever.
It physically prevents the exhaled CO2-laden air from traveling back down into the clean reservoir. It's incredibly efficient, allowing a non-rebreather to deliver somewhere between 60% and 90% oxygen concentration.
Wait, I need to flag something. You just said 60 to 90%, but the wall is pumping 100% pure oxygen into the bag. Why isn't the patient getting 100%?
Because it is physically impossible to get a perfect airtight seal between a mass-produced, rigid piece of plastic and the unique geometry of a human face.
Oh, of course.
Yeah, noses, sharp cheekbones, facial hair, jawlines, they all create tiny microscopic gaps. So when a patient takes a massive, forceful breath in, the vacuum pressure pulls some ambient room air in around the edges of the mask, diluting the stored oxygen.
The milk always finds a way to sneak into the espresso.
It always does.
Okay, I want to play devil's advocate for a second, looking at all this engineering. If the non-rebreather is so powerful and it gives the maximum possible oxygen, why not just use that on everyone who looks even a little breathless?
Just default to the strongest tool.
Yeah. Like if someone comes into the ER wheezing, just slap the non-rebreather on them, give them maximum oxygen, keep them totally safe, and figure out the exact diagnosis later. Why not default to maximum power?
Because, as we learned from the tragedy of the premature babies in the 1950s, maximum oxygen is never totally safe. And to see how dangerous that play it safe mindset is for adults, we have to look at the modern data.
Oh, right. I want to dig into that 2010 pre-hospital trial from Tasmania, the one published in the BMJ. Because reading through the stack of clinical trials we gathered for this, that specific data point completely stopped me in my tracks.
It's a huge study.
It proved that playing it safe with oxygen is actually lethal. Walk me through what those paramedics actually did in the back of the ambulance.
So the researchers set up this brilliant real-world trial. They took ambulance crews responding to patients suffering from severe COPD exacerbations and split them into two strict protocols.
Okay.
One group of paramedics followed the old-school traditional rule. They applied high-concentration oxygen via a non-rebreather type mask for the entire ride to the hospital, assuming more oxygen was safer.
And the second group?
The second group used targeted oxygen therapy. They utilized nasal cannulas or Venturi masks, specifically titrated to keep the patient's oxygen saturation monitor strictly between 88% and 92%.
A substantially lower, highly controlled target.
Exactly. And the result sent shockwaves through the medical community. The patients who received the lower, strictly targeted oxygen had substantially lower mortality rates.
Wow.
The data clearly showed that proactively giving COPD patients high-concentration oxygen in the ambulance actually killed more patients than it saved.
That is insane. I was looking at the notes you pulled on why this happens, and I have to admit, the physiology completely threw me. Because I've always heard this old medical rumor, a textbook myth really, that giving COPD patients oxygen, quote unquote, kills their hypoxic drive.
Right, you hear that all the time.
The theory goes that they retain so much carbon dioxide chronically that their brain gets used to it and they only remember to breathe because their oxygen is low. So if you give them pure oxygen, you remove the alarm bell and they just stop breathing. Is that what killed those patients in Tasmania?
No, and that concept of the hypoxic drive is a massive controversy. Frankly, it's a gross oversimplification that still haunts nursing and medical schools today.
Oh, really?
Yeah. It is critical to state that withholding needed oxygen from a severely hypoxemic patient, someone with critically low blood oxygen, is incredibly dangerous. You must oxygenate them. The real reason excess oxygen harms COPD patients isn't because they forget to breathe.
And what is it?
It involves two complex, beautifully intricate physiological mechanisms. The first is called VQ mismatch.
Okay, think of VQ mismatch like a smart highway system routing traffic. If you've ever had a bad chest cold or a localized lung infection, your body was actually doing this without you even realizing it.
Exactly. If a specific part of your lung is damaged or blocked by mucus, it isn't getting good airflow. And your body is incredibly smart. It realizes there's no point sending blood to a dead zone.
So it reroutes it.
Yeah, it actively constricts the blood vessels in that damaged area, diverting the blood flow, the traffic away to the healthy parts of the lung where the oxygen actually is.
It closes the broken bridge and reroutes the cars. But what happens when you strap a non-rebreather on that patient and flood the entire lung with pure oxygen?
You completely override the lung's own defense mechanism. The pure oxygen forces its way into the poorly ventilated, damaged areas of the lung.
And the body reacts to that.
Yes. The local blood vessels sense the sudden spike in oxygen and dilate, they open back up. The body thinks the bridge is fixed, so it sends blood back to the damaged area. But here's the fatal flaw. That area still has terrible airflow mechanics, meaning it cannot effectively exhale carbon dioxide.
Oh, no.
So you end up sending massive amounts of blood to parts of the lung that trap CO2 inside the body.
You literally trick the highway system into sending traffic into a dead end. That's wild.
And what is the second mechanism driving this CO2 trapping?
It brings us back to the Haldane effect.
Yeah.
Remember John Scott Haldane from the WWI trenches?
The continuous delivery guy.
Right. He discovered a fascinating quirk of blood chemistry. Hemoglobin is the protein in your red blood cells that acts like a molecular delivery truck. It can carry both oxygen and carbon dioxide.
Okay.
But when hemoglobin binds tightly to oxygen, it actually changes its physical shape.
Mm-hmm.
So when you flood the bloodstream with pure oxygen, the hemoglobin becomes so saturated that it chemically drops its grip on carbon dioxide.
Wait, really? Yeah, dumping all this extra trapped CO2 directly into the blood plasma.
So the patient isn't passively forgetting to breathe. The high concentration oxygen is actively forcing their own blood chemistry to dump toxic levels of trapped CO2 back into their system.
Exactly. And that sedates their brain and causes respiratory arrest.
That is, I mean, if we connect this to the bigger picture, it proves exactly why matching the specific device, the cannula, the venturi, the non-rebreather to the specific physiological need is literally a matter of life or death.
It's crucial. And this debate over hyperoxia, giving too much oxygen, isn't isolated to just COPD either. We see the exact same stakes in emergency resuscitation.
Really? Where else do we see this?
A landmark 2010 study by Dr. Stephen Kilgannon looked at post-resuscitation care. If a patient suffers a cardiac arrest and paramedics successfully restart their heart with CPR, the old reflex was to blast them with 100% oxygen to protect the brain.
Which again sounds perfectly logical.
Right. But Kilgannon's data proved that high arterial oxygen after a cardiac arrest actually causes severe oxidative tissue injury, and it leads to substantially worse neurological outcomes.
Wow. So even when a patient is literally brought back from the dead, the reflex to maximize oxygen is scientifically proven to be the wrong move.
Absolutely. And we watched these intense device selection debates play out on a global, terrifying scale during the COVID-19 pandemic, too.
Oh, right, because oxygen was the primary treatment.
Exactly. Early on in the crisis, there were massive arguments over using high-flow nasal cannulas, or HFNCs. These are highly advanced systems that heat and humidify the oxygen, pushing massive flow rates up to 60 liters per minute.
60 liters? That's insane.
It's a ton. And doctors desperately wanted to use them because they provided enough respiratory support to keep failing COVID patients off invasive, traumatic ventilators.
But there was a massive catch with pushing 60 liters of gas a minute into someone's nose, wasn't there?
Yeah, the fear was aerosolization. The sheer velocity of the high-flow gas could potentially catch the viral particles in the patient's respiratory tract and blow them across the hospital room in a fine mist.
Oh, massively increasing the infection risk for the nurses and doctors standing nearby.
Exactly. It was a brutal triage debate playing out in real time in ICUs globally. Do you use the specific device that might save this patient's lungs but risk aerosolizing a deadly virus into the ward?
And when you look at those global stakes, it wasn't just about infection control either. It was about sheer logistical volume. I mean, I am thinking of the devastating oxygen crisis in India during the spring of 2021.
That was truly heartbreaking.
The surge of COVID cases was so immense that hospitals were physically draining their bulk liquid oxygen tanks. When a hospital runs out of the sheer volume required to run thousands of high-flow systems, patients die. Choosing between placing a patient on a 2-liter nasal cannula, a 40% Venturi mask, or a 15-liter non-rebreather, it stops being just a technical, clinical decision. It becomes a massive public health and emergency logistics puzzle, and healthcare workers are solving it minute by minute, trying to stretch a finite resource.
It really is the front line where applied physics meets public health infrastructure.
Mm.
You are trying to control an invisible, highly reactive gas within a biological system that is constantly deteriorating and changing.
So what does this all mean? We started this deep dive by stating that oxygen is not just air, but better. It is a highly regulated, potent prescription drug.
Exactly.
The flow rate coming out of the wall is not the same thing as the fraction of inspired oxygen actually reaching the lungs. Oxygen has a very real, very dangerous therapeutic window. And that simple piece of plastic sitting in a sterile wrapper on a hospital tray, it isn't just a mask, it's a highly engineered tool designed for a very specific clinical mission.
And using it correctly requires a deep, interconnected understanding of fluid dynamics, pulmonary anatomy, and intricate blood chemistry.
I can guarantee you the next time you walk through an emergency room, or you see an ambulance rush by with its lights on, or you just sit on your couch watching a medical drama on TV, you are going to look at those clear plastic tubes completely differently.
You definitely will.
You won't just see a prop anymore. You now know the secret language of the devices. You know whether that TV doctor is accidentally ordering a variable, unpredictable espresso shot or a precision-engineered 28% mix.
Which raises an important, lingering question to leave you with today.
What's that?
Despite all this incredible engineering we've explored today, our highest delivery, most advanced oxygen masks on Earth still max out because ambient room air inevitably sneaks in around the edges of the face seal.
The milk sneaking into the espresso.
Right. But what happens when we push the human body into extreme environments where room air itself is toxic or entirely non-existent?
Yeah. If our entire modern medical foundation relies on the physics of diluting pure oxygen with ambient room air, how do we completely rethink and re-engineer these delivery devices for a medical emergency during a saturation deep sea dive or, in the rapidly approaching future of deep space medicine?